Okay, so we'll get started. So today we're going to discuss some of the medical presentations that can come up in your OSCEs, but also as multiple choice in the AKT. And we'll start with cardiac, respiratory, and constitutional symptoms today. And then SLA will continue with some of the other ones, and then Emma will finish with surgical presentations later. Okay, so it says in your curriculum that you need to know sort of how to come up with a differential diagnosis, take a focused history from a patient with that differential diagnosis in mind, and then discuss investigations, and finally come up with like a simple management plan, or at least the principles of management without having to detail doses and things. There are some situations where I think they do expect you to know doses, and that's like emergency situations, such as anaphylaxis or cardiac arrest. But we'll have a proper emergency presentations lecture later. Okay. And before we discuss the presentations in detail, I'm just going to go through a framework on sort of how to approach focused histories and discussing investigations and management, either to the examiner at the end of an OSCE or directly to the patient. So if you're taking a chronic history, they might ask you to take a history, come up with the best possible diagnosis, and then explain what you're going to do next to the patient. So if we start from outside the OSCE station, when you read the vignette, you should be able to come up with a differential just from the presenting complaint. And at this stage, when you're waiting outside in those 2 minutes, it's nice to think about what the sort of worst case scenarios are. So what are the red flag symptoms that you have to screen for? And what pathologies are you looking to exclude? Obviously, it's fine if you don't get or it's relatively fine if you don't get the diagnosis at the end of the station, but they can fail you on the grounds of being unsafe. And they could say that if you don't rule out a certain pathology for this presentation, you're being unsafe as a doctor. And so you want to avoid that. And then on entering, speaking to the patient, the golden minute is maybe a bit optimistic in an OSCE, but let them elaborate a little bit. So if they give you a single line when you say, what brings you in today, just get them to speak a bit more, to say something like, tell me more, or can you expand on that? Anything. And then once they've given you like a brief story, you can get into the details of the presenting complaint. So even if it's not a pain presentation, you can use Socrates, just skip like site and things like that, and radiation. But you still need to know onset, duration, the timings, is it constant, intermittent, the character of the symptoms, and what makes it better or worse, including have they tried any medications that would make it better. At this point, it's nice to discuss the functional impacts. If they've come in with a symptom, especially if it's a chronic symptom, ask what's your baseline and how is this new presentation affecting your life or your function. And then if it's a more acute presentation, you can ask them if it's happened before. Okay, from this point onwards, when you're asking about red flags, past medical history, family history, it's your opportunity to tailor it to the specific presentation and show the examiner that you're not just taking a generic stock history for everybody, and that you have something in mind that you're narrowing down. So obviously red flags should be tailored to the specific complaint. The past medical history, they should typically just tell you everything they have, but there are certain things, if there's very like clear associations, that you can directly ask for. For example, if someone's presenting with something that you think very much sounds like asthma, you can establish if there's a history of ATP by asking specifically, have you ever had eczema as a kid? Do you have any food allergies? Things like that. The family history you might need to tailor more, because you can't just ask them, what's your relevant family history? They're going to say, what does that mean? Typically, you can ask for cancers or cancer syndromes, cancers that associate together. Secondly, based on the system that you think is affected, you can ask irrelevant. So if they're coming in with shortness of breath, have you got any family history of respiratory conditions? When I've written metabolic there, I mean things like diabetes or high cholesterol, for example, if they've got a cardiac presentation. ATP we've just discussed, so if they're presenting with anything that sounds like any of those, ask for a history of any of the others in the family. And autoimmune conditions can associate together too. Drug history, again, they should give you everything that they take. Ask for allergies at this point, and specifically for anything recreational. And finally, in the social history, there are four main things that you should always ask: smoking, alcohol, occupational, like what do they do during the days, and their home situation. And if it's an elderly person, especially you need to check how independent are they? Can they do their activities of daily living? Then the others are tailored to your um, presenting complaints. So things like foreign travel, you don't really care unless they're presenting with weird infectious symptoms or lymph nodes. Diet and exercise might be more relevant in a GI presentation. And driving, you have to ask to be safe if someone's coming in with things like syncope or daytime sleepiness, again, screening for driving and using heavy machinery, things like that. Okay, so that's the history. Going on to next steps. This can be done for basically any patient. You want to examine them first. You can say take a full set of obs and then investigations. You've probably been told to start from the bedside, things like ECGs, urine depths, and then go outwards to imaging. Oh, sorry, outwards to more invasive things first. So bloods, APGs, and then to imaging, then to specialist tests. In certain presentations, it's more relevant with surgical things, I think. So things like upper GI bleed, there are certain scoring systems that you can use to predict outcomes. Oh, and I guess in things like pneumonia, you want to calculate a curve 65, and so you might need to take specific measurements or ask specific things. If it's an acute presentation, you can't really go wrong by saying discuss with a senior or discuss with an MDT. But if you're in a GP setting, you can bring in other healthcare professionals. So, for example, if you diagnose someone with COPD in your OSCE, you can say refer them to the COPD nurses, asthma nurses, diabetes nurses. You can always give someone a leaflet if you're giving them a new diagnosis. And this is especially important in the community, but also if you're in hospital. Always safety net, even if you think your top differential is something benign or chill, safety net them for either if something gets worse and they have an exacerbation, or if you've got the diagnosis wrong, other things that they should look out for. Then management, typically you shouldn't have to have a scenario where you're resuscitating someone. If you did, you can just say you're doing an A to E approach. Otherwise, for management, you can divide this into symptomatic relief, a definitive management, or referral to secondary care or a specialist team, and general lifestyle advice. Okay. We'll go on to our proper presentations now, starting with chest pain, which I'm sure you discussed a lot. So the main causes of chest pain for which there are like serious pathologies are cardiac causes, respiratory causes, GI causes, and vascular causes. There are some other miscellaneous ones that I've included in these other boxes, and we'll discuss those. So starting with cardiac causes, in bold are the things that can kill a patient if you miss them or cause cardiac arrest and kill. And for cardiac causes, those are myocardial infarction and tamponade. The other things to look out for are angina, heart failure, outflow obstructions, so either aortic stenosis if it's an elderly person, or HOCM if it's a younger person or someone who's just, like passed out during a match. Respiratory causes to make sure you don't miss. Things that can cause cardiac arrest are pneumothorax and pulmonary embolism. Asthma exacerbations can also be life-threatening, and obviously you don't want to miss a lung cancer as a cause of chest pain. For the GI causes, the main one is Boerhaave syndrome that could kill by like shock. But otherwise, you're thinking about things that are in the chest, mediastinum, so esophagus, and sometimes peptic ulcer disease can like radiate upwards, or gastritis. Aortic dissection, again, is the vascular cause you really don't want to miss. And then here, so this fifth box is the sort of miscellaneous, so acute chest syndrome and sickle cell. Things that are sort of skin and soft tissue, so shingles on the skin surface and breast pain in women. MSK, so rib fracture and costochondritis, and that chest pain will be reproducible on palpation, so you can distinguish from some of the other causes. And obviously, panic attacks can present with chest tightness, shortness of breath, and can make you think of MI. If you are giving that diagnosis, you want to be sure that you're not missing an MI, so just do all of the investigations as you normally would. And then in this final box, I've included pain that you might expect to be somewhere else. So pancreatitis and cholecystitis, you'd expect to be in the upper abdomen, but they might experience it as chest pain. So make sure you ask relevant questions there. Okay, and then what are the relevant questions? So in the history presenting complaint, you can take your full Socrates, and it's really important to establish, especially the onset, duration, and the timing. So is it a continuous chest pain? Is it getting worse, better? Or is it intermittent? And if it's intermittent, are there any triggers or exacerbating factors? And a key exacerbating factor to ask for here is exertional chest pain. So that can point you towards a cardiac cause where you have outflow obstruction, something like aortic stenosis. Um, Sorry, so the associated symptoms again can point you towards different um, or narrow down your differentials. If you're having chest pain with palpitations, it's almost always going to be a cardiac cause, unless it's like panic disorder. If you have sort of the combination of shortness of breath plus swelling, you might think it's heart failure. Whereas if you have shortness of breath plus productive cough, it might lead you more towards like a pneumonia or respiratory cause. It's important here to especially to ask about reflux. That's something that people might miss because if you think chest pain, you're thinking heart and lungs, but you want to make sure it's not like GORD, even if they have chest pain plus cough. Okay, and then past medical history again will help you narrow down further. Um, if if you have like hypertension and cardiac problems, kidney disease, then you might think a cardiac cause. A recent viral illness might point you towards myocarditis, pericarditis, or pleurisy. And so inflammation of the pleura. Cancer and recent surgery. So you want to rule out any pulmonary embolism. So you can ask about VTE risk factors here. Drugs, again, they should just tell you what they take. But here, things to look out for, any clues they give you. If they're taking cocaine, it could be a coronary vasospasm. And if they're taking NSAIDs, antiplatelets, steroids, bisphosphonates, then you might think it's a like ulcer, peptic ulcer disease. Okay. Then going on to investigations. So we'll talk through this framework once, and then for the rest of the presentations, we'll just discuss the specifics that are different. So again, we're starting with examination. So a full cardiorespiratory exam. If you think it's an abdominal cause or that's not been struck off your differentials based on your history, then you can do an abdo exam as well. For the OBS, again, you're always going to say a full set of OBS. Here you can be clear and include taking blood pressure in both arms to rule out aortic dissection. Then in the bedside, if you're suspecting acute coronary syndrome, so if someone's got squeezing chest pain, sweating, clammy, history of like hypercholesterolemia, things like that, then you need to do serial ECGs. So two ECGs, 30 minutes apart to look for changes that develop. If it's like a respiratory cause that you're suspecting, chest X-ray, and ultrasound can be useful if you're if it's like traumatic and you're thinking about hemothorax or want to rule out blood in the pericardial space causing tamponade. For the bloods, all of the standard bloods, U&Es you can kind of say in most presentations because you might need a baseline electrolyte screen and renal function screen before you can prescribe medications. Here an FBC is relevant for anemia, which can give you exertional like tightness. CRP and ESR is also, you can pretty much always say it to rule out something infectious. LFTs and TFTs are relevant here because of cardiac issues, and BNP to rule out heart failure, and finally an amylase to rule out any pancreatitis. Imaging will be dependent on your top differential, but key ones to remember are CTPA to rule out PE, and echo for valvular pathology, and if you think they have heart failure, to measure the extent or the severity of heart failure, because you can measure ejection fractions. Sorry, let's go back. There are some Socrative questions based on chest pain. I haven't discussed management here because most of the emergency ones we'll discuss in that other lecture. And yeah, if if you guys, sorry, go on to the Socrative. First question is an 18-year-old man, left-sided chest pain, breathlessness, and cough. And the pain is worse by breathing in, so pleuritic chest pain, no fever. And here the key findings are breath sounds reduced over the upper half of the left side. What's the most likely diagnosis? Okay, fine. So a lot of you have answered already, and most of you have got the right answer, which is spontaneous pneumothorax. Um, so here we'll point you towards this. Uh, Sorry, so most of you are picking between the left upper lobe pneumonia and spontaneous pneumothorax. From the history, it's hard to differentiate the two. So pneumonia can also cause a pleuritic chest pain that's like focal if it's a lobe problem. Both will cause cough, breathlessness, and yeah. The fact that he's not got a fever sort of points you away from pneumonia, but I think the key thing is that the breath sounds are reduced, which is classic for pneumothorax, whereas in a pneumonia, you're expecting like bronchial breath sounds. Usually they would give you some other clues, I suppose. But yeah, I think also the fact that it's a young person, young men especially can have spontaneous pneumothorax and look for clues such as like Marfan's or other connective tissue disorders. They're less likely to come in with like pneumonia, right? Like you typically expect that to be an older person. And if it's a young person, you're expecting more of like an atypical picture. Okay, cool. So next question, 65-year-old man brought to ED, 1 hour of central crushing chest pain, shortness of breath, sweating, history of hypertension, and what's the most appropriate initial investigation? Perfect. So most of you have said ECG, which is correct. Troponin will be raised, but your first investigation will always be, starting from the bedside outwards. And we've talked about how we need two ECGs 30 minutes apart for anyone in whom we suspect acute coronary syndrome. Um, Sorry, this is a short answer question. So an 83-year-old man, 2 months of breathlessness on exertion, left-sided chest pain and weight loss, no fever and no sputum. He's a retired builder, no smoking history. Left side of chest is dull to percussion, diminished breath sounds at the left base. And they've given you the chest X-ray findings, which show diffuse pleural calcification and a left pleural effusion. What's the most likely diagnosis? No worries if you get this wrong, and you can be as vague as you like. Obviously, this would be a multiple choice in the thing, in the AKT. Perfect, thank you. So I'm going to wait for a couple more. Okay, perfect. So I've got a range of answers. So the correct answer is mesothelioma. And how do we know this? So firstly, looking at the presentation without our investigation findings. So he's got breathlessness over a sort of chronic history, so 2 months. Um, Chest pain with weight loss as well. And the weight loss is concerning here. Um, Retired builder also points us towards the diagnosis. And then looking at his examination findings, left side of the chest, dull to percussion, diminished breath sound. So it's like a focal problem. And then our chest X-ray clinches the diagnosis. Here, so we're picking between either a lung cancer or a pleural cancer. And I'm sure they told you loads in lab med that like the most common cancer in someone who's got a history of like asbestos exposure is just bronchial carcinoma. Um, but the other way around is true. So if you have a mesothelioma, then it's very likely that they had asbestos exposure. So pleural calcification and pleural tumor is mesothelioma and can cause an effusion. Obviously, lung cancer can too. Um, why is it not pulmonary fibrosis? You'd probably expect like fine crackles, and you wouldn't really expect such like acute weight loss over 2 months. Yeah, perfect. Good. Okay, so let's move on to our next presenting complaint. We'll pause the software for a second. So shortness of breath. We can divide the causes of shortness of breath into like four main things. If you don't really care about like frameworks, then you can just ignore this bit and we'll talk about the actual presentation soon. But in terms of the causes, we can go from central causes in the brain, so things that are increasing our respiratory drive. So this can happen in things like panic attack, um, also as a response to acidosis, so the labored breathing that you get in DKA, for example. And then our second cause is problems getting the air in, so insufficient oxygen delivery to the lungs. And that can be due to like failure to breathe in properly, so neuromuscular cause, but can also be like lung pathology, so obstructive path or bronchospasm. Thirdly, insufficient oxygen, like getting to the blood from within the lungs, and that can be the problem in like alveolar pathologies, um, fluid buildup in the lung interstitium, for example, or VQ mismatch. And then finally, if there's not enough oxygen getting around, we can still sense hypoxia and increase our respiratory drive. So that can be the case in like heart failure, so reduced ejection fraction, outflow problems, so aortic stenosis or HOOCM, and anemia. Fine. But in terms of our shortness of breath, like taking the history, what do you think is the first thing? So if you read in the vignette, they're presenting with shortness of breath. What's the first like detail in the presenting complaint that we need to establish first? This is a question on the Socrative. Sorry to make you flip back. Just going to wait for a couple more of you to answer. Right, so I've got a range of answers actually, and some of them are good. So one of them is to check if they have a patent airway, which is true. So if someone's like coming in with shortness of breath and you have no other information, you obviously want to make sure that they're not like peri-arrest, like completely hypoxic. And if they are, then start your AT approach. Um, Someone said like trauma to exclude tension pneumothorax, and yeah, in the same vein, if someone's got like an emergency presentation, like trauma or peri-arrest, then you need to sort all of that first. Um, but the the thing I was trying to establish, or the thing that will lead us onto our next slide, is the timing of the shortness of breath. So how acute is the onset? Not just if they've, so either have they had it for months or weeks, which is the box on the right. Have they had it for like hours to days in the middle, or is the onset like very acute, so within seconds to minutes? A lot of the causes of acute onset, like hyperacute onset shortness of breath, are like life-threatening. So you want to establish that first, and then you can ask the next questions in the like history presenting complaint. Just quickly going through these three different like differentials. In the first one, Sorry, so in bold are the things that you should exclude, but a lot of the ones in the left will be life-threatening, as I said. So firstly, anaphylaxis, inhaled foreign body, or laryngeal edema, so swelling that's not due to anaphylaxis, is an obstructive problem. And then lung pathology, so bronchospasm, like an asthma, pulmonary embolism, pneumothorax. And in the subacute causes, you don't want to miss a pneumonia, especially in like an elderly person. Other RASP causes are lung collapse or alveolar pathologies like atelectasis or ARDS. Cardiac problems can still present with shortness of breath, so in heart failure, an exacerbation can be like subacute rather than chronic. And then we've talked about, I mentioned before, so the neuromuscular causes, so Guillain-Barré, we classically think of as an ascending weakness, but the failure of respiration can cause mortality. And myasthenia gravis can produce resp fatigue. And then finally, the chronic things are the classic, like chronic lung problems, asthma, COPD, interstitial lung diseases. And then want to rule out TB and lung cancers. Cardiac causes that are chronic are heart failure, and I mentioned the like outflow problems, aortic stenosis. And then long-term neuromuscular causes, motor neuron disease. Right, so things to establish in the history of presenting complaint if it's not like hyperacute. You want to see if it's like continuous shortness of breath or is it worse at certain times? And if it is, then what's the trigger? Any exacerbating factors? Is it worse on exertion? Like with the chest pain, that will point you towards a cardiac cause. Or like an atypical pneumonia can present that way, like the walking pneumonias. If it's worse on lying flat, you might think fluid buildup. If it's seasonal, then you're thinking like asthma. For shortness of breath, especially if it's chronic, it's nice to ask about the baseline and the functional impact here rather than in the social history. So asking questions like, especially if it's an elderly person, how far can you walk normally, and what about now, to determine how severe it is, whether they need to be hospitalized or not. Associated symptoms. So someone said here that one of the first things you should ask is about chest pain, which is true, but some of the benign causes of shortness of breath can also cause chest pain. In terms of like asking in the history, it's important to say like, do you have chest pain? And then is it with the shortness of breath, or is it, and sorry, if it is with the shortness of breath, then do you always get chest pain with shortness of breath? And then thirdly, if you do get both together, which one came first? Like, did you get chest pain first and then shortness of breath, or did you have shortness of breath for like a few weeks and then your chest started to hurt? Because obviously, if you're like breathing in and out deeply, then you can just develop like respiratory fatigue or intercostal muscle irritations. The other ones are obviously constitutional symptoms to rule out cancers and hemoptysis and cough as well. Signs of DVT to rule out PEs and blood loss, especially if it's all women. Women check for like dysmenorrhea, and for everyone else, like GI bleeding, to rule out anemia. In the past medical history, again, you shouldn't really need to ask for specifics, they should just tell you. But these are clues to look out for. So if they say they've got some of these autoimmune conditions, then they can cause inflammation in the lungs as well. A to B can point you towards asthma as the cause. A recent surgery can not only predispose you to like clots, but also post-op atelectasis. If they've got any pre-existing cardiac problems, then it could be heart failure, liver problems, especially if it's a young person that sounds like they've got COPD vibe, then check if they've got any early cirrhosis or other symptoms. Then for the drug history, I have a SOCSHIP question. I'm just going to check if it's the next one. No. Okay, so there are certain drugs that you can ask about that can cause pulmonary fibrosis, and when we do the question, I'll go through the list. And then in social history, especially if it's a younger person and asthma is like at the top of your differentials, we need to ask about pets, like mold at home, dust, allergies, and we've already talked about like, is it seasonal, are there specific triggers? You can also ask about foreign travel to rule out things like TB or certain Pneumonia is like Legionella, where you're likely to get it from like classically conferences with like bad aircon. Occupation, like in our previous vignette with the man who was the builder to look for asbestos exposure, or other environmental like farmers, builders. Okay. Let's do the next two sort of questions that are about shortness of breath diagnosis. So this next one is a 65-year-old man, SOB on exertion, it's gradually worsened over 6 months, with no associated cough or wheeze. There's a history of hypertension, he's taking antihypertensives, long smoking history, but stopped smoking 15 years ago. His obs look normal except for 92% stats. Clubbing, fine late inspiratory crackles at both lung bases. What's the most likely diagnosis? Okay. I think most of you have answered correctly. So this is idiopathic pulmonary fibrosis. Looking through the other answer options. So bronchial carcinoma, he seems to have no other concerning symptoms, so that shouldn't be top of your differentials. For example, if you had this guy like come in and you're taking a history. Bronchiectasis can present with clubbing, but it's usually with a productive cough as well, and or recurrent chest infections. Doesn't sound like heart failure, even though he has this history of hypertension. Why not? Again, because no other like symptoms, no swelling in the legs, for example. And it doesn't say that it's worse on lying down. Now, picking between COPD and pulmonary fibrosis, so given his long like pack year smoking history, COPD should be up there, but it's his examination findings that point you towards IPF. So fine late inspiratory crackles, like the ones that sound like you're walking in snow or like Velcro, is classic for IPF. And you don't get clubbing in COPD. I can't remember, there's some mnemonic for like respiratory causes of clubbing, and I think like one of the C's is not COPD or something. So just remember that most other lung pathologies that cause hypoxia, so bronchiectasis, IPF, some lung cancers can cause clubbing, but not COPD. Okay. Next question. So this is our drug question. So do you guys know which of the following drugs can cause drug-induced pulmonary fibrosis? You might hear this called hypersensitivity pneumonitis. So picking between phenytoin, bleomycin, bisphosphonates, cisplatin, metro. Oh, okay, so a lot of you have answered. So the correct answer is bleomycin. This is something to just memorize, I think. So we've got our mnemonic kind of just an acronym, I guess, on the screen. So babam, bleomycin, busulfan, both of those are like chemotherapy agents. Amiodarone, an antiarrhythmic. Methotrexate, it's a bit contentious, but classically methotrexate is meant to cause pulmonary fibrosis. So someone with rheumatoid or some of the like autoimmune skin conditions can be on that. And nitrofurantoin. Something to just note, normally if they I mean, they could ask you in the AKT, but also if someone drops it in their drug history, then it's nice to note it. Okay. Investigations for shortness of breath. So we're just going to talk about the specifics now. All the other exams, most of them are the same. So the bedside test, if you're thinking about asthma, then start with peak expiratory flow rate. And you can ask them to do a peak flow variability diary in the community, where they're recording their peak flow like over a week or so. If it's COPD or interstitial lung diseases, then you need to do spirometry. Obviously, for COPD, for the diagnosis, you need not just the spirometry findings of an obstructive course, so FEV1 over FVC reduced, like below 0.7. You also need the history of like 3 months of productive cough over at least 2 consecutive years. For the interstitial lung diseases, remember that the spirometry finding will be like normal or raised ratio. Then, if you're thinking a pneumonia, but it's a younger person, they don't really have the classical features, then you can do a COVID test or the urine test for Legionella. Whenever you're considering lung cancer in your differentials, then the first line investigation, this is the same for our AKT, the first line investigation will be chest x-ray. On the other hand, if you don't think it sounds concerning, so it doesn't sound like lung cancer, there's no red flag symptoms, but you think it's like an interstitial pathology, then you can go straight to high resolution CT chest, or that will be the answer if they ask you for like the gold standard diagnostics. CTPA again for PE. And then management. So again, the acute or the emergency things we'll discuss later, but for the chronic ones, you might need to discuss very briefly to the patient at the end. For all of these, remember our framework of lifestyle, symptomatic management, and definitive management. For COPD, they'll probably require an inhaler, but you also need to, if they mention smoking in the social history, then you need to tell them to stop it. You can tell them you're going to refer them, or you can refer them to a smoking cessation service. For heart failure, the meds that you're going to, you don't even need to know the specifics if you're speaking to the patient, but you can tell them you're going to start them on some medication to improve their symptoms, so the diuretics, but also to improve mortality. So that's the others, the ACE inhibitors and the beta blocker. But you also need to instill some lifestyle changes, so restricting their salt intake, reducing their weight, and don't do anything too crazy with the exercise. Oh, and I forgot to say, so the new guidelines include SGLT2 inhibitors as well to start with because they improve cardiovascular outcomes. For the pneumonia, you can just say you're going to start them on antibiotics as per the guidelines. You don't need to know specifics, but typically for a community-acquired pneumonia, it's amoxicillin to start. There are different guidelines on whether you have to repeat chest X-rays. But the repeat in 6 weeks one that you might have been told to check if there's like a cancer underneath the pneumonia is only really relevant if the pneumonia was complicated to begin with, or if the patient has a high risk of malignancy themselves. For asthma, there's two different types of management. So if it sounds like they just have clear triggers, for example, like when they're exercising or in the cold, then you can give them this reliever therapy, which can be used as needed. So when they feel like they're having a flare-up, they can just take the combined corticosteroid and long-acting bronchodilator. There's also another therapy that you can take once a day, so maintenance and reliever therapy, which is the same combination, but taking it once per day. Fine. Okay, so going on to cough, and we'll like briefly discuss hemoptysis with this. For cough, we can split them we'll discuss all of the characteristics of the cough that you need to ask, but just generally you can split it into acute versus chronic cough. Acute is less than 3 weeks, and a chronic cough is greater than 8 weeks. And then dry and productive. So acute dry coughs are things like the common cold, or other upper respiratory infections, asthma, exacerbation. Productive can be lower respiratory tract infections like pneumonias, or things where you typically have a productive cough and it's exacerbated, so COPD and bronchiectasis. For chronic dry, the most important one to rule out is cancer, not just lung cancer, other mediastinal cancers. These can also present with shortness of breath, so any mediastinal mass, so things like Hodgkin's lymphoma, any sort of like thyroid mass, thymoma, all of those can present with shortness of breath / cough. And some things to tease out in the history are if they have GORD or postnasal drip causing the cough, because those aren't as serious and you don't need to send them down like a respiratory pathway. For chronic productive cough, it's like the things we've already discussed, so COPD and bronchiectasis, but also you want to rule out TB, so looking for constitutional symptoms, foreign travel. Mm. Sorry, for the history. So these are the characteristics of the cough that you need to ascertain. So we've already talked about how long have you had the cough for? Is it a constant cough or is it intermittent? And if it's intermittent, are there like specific triggers for the cough? The characters, is it breathy, productive, wheezy? Sorry, breathy or wheezy. Productive and dry is different. And if it's productive, you need to ask characteristics of the sputum. So how much sputum? What color is it? Is there blood in it? Is it frothy? Frothy can point you towards like heart failure, whereas blood, you want to rule out PE and cancers. But note that bronchiectasis can also produce like hemoptysis. Fine. You can also ask about if there's anyone else with similar symptoms. This is true for anything that you think is infectious, so not just respiratory infections, but also GI. So if someone's presenting with nausea, vomiting, you can ask if anyone else in the household or at school has similar symptoms. For the constitutional symptoms, you can ask specifically about runny nose, sore throat, other upper respiratory tract infection signs. And wheeze associated with a cough is fairly specific for asthma. Reflux symptoms will point you towards GORD. Okay, again, most of this is the same, except for these bedside tests. So you can take a sputum sample and culture. You might need to do certain stains for TB. Nasopharyngeal swab for viral causes. Again, the urinary antigen. And again, always chest x-ray first if you think it could be a lung cancer. Okay, there are two more questions on the Socrative, I think. Yes, okay. So the 62-year-old man with 4 weeks of a 4 weeks of a blood-stained sputum producing cough, tired, breathless on exertion, lost weight, has a 40-pack year smoking history, currently taking a 5-day course of amoxicillin, but his symptoms are unchanged. The next best thing to do. Perfect. This is full of red flags for malignancy. I have to do a chest x-ray first. You'll end up having to do a CT chest, obviously, to characterize the tumor and things. But x-ray first. Sorry, next question. So 56-year-old man, 2-week history of fever, malaise, and increasing breathlessness. Off work with a cough and malaise for 3 weeks. 25-year pack year smoking history. So he's febrile. Everything else kind of normal. SAT 94. Okay, and then they've given you the examination findings. Okay, so a lot of you have answered. This is the main question, but this could come up in either LabMed or AKT, but they could also give you these, if you're in a RESP exam station, they can give you these findings and ask you for your differentials, which we had either in our exam or in our mock. So most of the history is kind of vague. It could be any of these answers, especially pneumonia, infective exacerbation, or empyema. So we're looking at the three infective pathologies because he's got a fever and he's generally feeling unwell, and it's subacute, only 3 weeks. Now, infective exacerbation of COPD. So it's likely that he could have COPD because of his smoking history. Um, Both this one and the lobar pneumonia would present similarly. And if we look at his examination findings, so reduced movement of the right chest, dullness to percussion, reduced breath sounds, and absent vocal resonance over the right lung base. So the reduced breath sounds we've already discussed. So in a pneumonia, you're more likely to get bronchial breathing rather than reduced breath sounds. You will get dullness to percussion, but the vocal resonance really clinches it. So in pneumonia or COPD, you've got increased density in the lung tissue itself. So you're going to have increased vocal resonance. If you've got absent vocal resonance, there's something in between the lung and the like chest wall. So there's something in the pleural space. So here it's going to be an empyema, but things like pleural effusions that aren't infectious, so malignant pleural effusions can also present like this. Um, Hopefully that makes sense. So you have to, it's like nitpicky, but you have to go through every line of the investigation findings and the examination findings. Okay. Oh, sorry. This is the next one. So we can pause and go back to our PowerPoint to our next presentation, which is syncope. So syncope is like transient loss of consciousness. There are different causes. Obviously, if you're taking a syncope history from someone in real life, one of the like top differentials that you need to rule out is seizures or some sort of neurological cause, like a brain bleed. Here, they wouldn't give you it's less likely to be a neurological diagnosis, but you still need to rule out seizures when you're taking the history out of someone. So let's think about the other causes of syncope. Firstly, reflex. So these things aren't so serious, but vasovagal. Vasovagal like attacks have a precipitating factor. So usually it's like if they're dehydrated or something like, or they're taking some drugs that are predisposed, and then something that like causes the event. So if you're scared about something or if you see blood and then you faint, and they usually have a prodrome as well. So they feel nauseous or shaky or sweaty or they go pale. Carotid sinus hypersensitivity. Some of the clues in the history will be if it comes on when they're like doing up their shirt or a tie, something like touching the neck. Then cardiac causes. So these are the ones that you need to rule out. Any arrhythmia can cause syncope. The outflow tract obstructions again, and pulmonary embolism. Orthostatic is so like postural hypertension. So if you stand up and faint, then it's likely to be one of these causes. Then cerebrovascular. So again, subclavian steel isn't so important, but there's the mechanism of how it works if you're interested below or on the side. And aortic dissection you need to rule out. And these are the things that you need to ask about in the history. So intracranial bleed, hyperglycemia you can investigate, and seizures. Okay, so going on to our history. So whenever you're taking a syncope history, it's similar to if you're taking a history of a fall. You need like a before a fall, during, and after. So before, you're going to ask if there is any prodrome. This is the things we've talked about before. Palpitation specifically can point you towards a cardiac or like an arrhythmia, that sort of cause. Whereas just feeling pale and clammy, nausea doesn't necessarily mean it's cardiac syncope. It can just be vasovagal. Other precipitating factors. So this is what I was saying. So if it's like fear or blood, then it's more likely to be vasovagal, whereas standing up can be orthostatic. And a history of head trauma. Then during the loss of consciousness, you want to establish like how long were they unconscious for / on the floor for. Signs of seizures can be tongue biting and incontinence. They might not know if they've bit their tongue, especially if it's not been witnessed. But you can ask them if they taste blood in the mouth. And any loss of continence. Then you can ask them if their muscles were stiff or floppy or jerking. Jerking doesn't necessarily mean seizure. Some cardiac syncope can present with like brief movement of the muscles as well in a way that sort of looks like a seizure. And then you can ask them if they fell, where did they fall, onto what sort of surface, and is there any trauma anywhere else? And then afterwards, the sort of like post-ictal state if it's a seizure. How long did it take? And if you do feel confused and drowsy, that points you more towards a seizure than towards like a vasovagal, where they would recover pretty quickly. Okay, in the past medical history, some key things to ask about are epilepsy, cardiac problems, and diabetes. Diabetes for the orthostatic syncope. Anemia can also cause syncope if you stand up too quickly and you feel dizzy and you fall over. And obviously, we're still thinking about PE as our like serious cause, so you want to ask about the VTE risk factors again. The drugs, again, you're not going to ask for these, but if they mention them in the history, then it can point you towards certain diagnoses. If they're taking insulin or sulfonylureas, then that can be just a period of hypoglycemia. Stimulant recreational drugs, so amphetamines, cocaine can precipitate arrhythmias, especially in young, healthy people. And you can see if they're on the OCP or other drugs that increase your risk of thrombosis. In the social history, so I mentioned at the beginning, it's really important here to ask about driving and occupation, if they're doing anything that operating machinery, driving generally, you need to be safe and give them advice. And then, yeah, seeing if they're drinking alcohol, which can also precipitate arrhythmia. Fine. And then investigations for syncope. You want to, again, so a cardiovascular exam and a full neurological exam, including peripheral neuro, because you can look for signs of like sensory deficits, glove and stocking that can point you towards diabetes. Any signs of trauma from if they fell over. Again, a full set of obs, but here specify that you want to take a lying and standing blood pressure to look for orthostatic change. And that's a drop of more than like 20 millimeters mercury. Really important to rule out hypoglycemia, a really reversible cause. If you don't correct it, it can cause neurological dysfunction and seizures. So say that you want to take a CBG at the bedside. Also at the bedside, ECG must be done to rule out cardiac causes. Even if it sounds vasovagal, you still can rule out arrhythmia with a quick test. Then if you're suspecting certain things, you need to do an echo if you think valvular pathology. And if you think anything neurological, you can start with a CT head. Yeah, okay. We'll talk about driving advice. I'll ask you guys first, but we'll do one more Socrative question, multiple choice. Okay, so this is a 72-year-old presenting with episodes of dizziness and one episode of syncope while climbing a flight of stairs. Associated shortness of breath and a mild central chest discomfort on moderate exertion. Denies palpitations or nocturnal symptoms. Pulse is regular, blood pressure normal, respirate 18. JVP not elevated, and the examination findings, there's an ejection systolic murmur, best head in the aortic area radiating to the carotids. What is the single most definitive investigation to confirm? Okay, perfect. So this is classic aortic stenosis in an old person with exertional symptoms, so shortness of breath, syncope, dizziness, chest pain, all on exertion, and the classic murmur. In the AKT, make sure you're checking the last line. You can even read the last line first, looking at the question first, then read the vignette to make sure that you're looking, if they're asking for the definitive investigation, the best investigation, or the like next investigation, so like the first one to do. Okay, and then if you do suspect a cardiac cause, or an epileptic cause for the syncope, what driving advice should you give them while they're waiting for this assessment? Yeah, perfect. Obviously, don't drive until this next assessment. Then they'll give you proper advice. And you should also tell them that it's their responsibility to inform the DVLA. So before this diagnosis, or before a diagnosis is given at the assessment, you don't have to do it, especially if you're an ED or if you're the GP. They have to tell them. Perfect. Okay. Okay. Let's pause before that next question and go on to our next set of presentations. So palpitations and new murmurs. Okay. So this is again, a lot of the history of presenting complaint, past medical history is going to overlap with what we've already discussed for all of these other cardiac and rest presentations. So I've just sorted the causes of these two presentations here. The main ones for palpitations are um, figure out if it's a cardiac cause, so not just arrhythmias and ACS, but also high output states. And those can include anemia, pregnancy, sorry, thyrotoxicosis, and also Paget's disease of the bone. Certain drugs can cause palpitations, sympathomimetics, obviously, vasodilators. I forgot to include it here, but beta blocker withdrawal can present with palpitations. Obviously, all of the stimulant drugs. I've already said the panic attack can present similarly to ACS with palpitations, squeezing chest pain. You can ask them actually in the past medical history if they've got any like psychiatric diagnoses as well. You can show the examiner that you're looking out for this. And endocrine causes pheochromocytoma. This can also present with episodic headaches and raised blood pressure. Okay, and the new murmur I've sorted by the like location of the murmur. Mitral is probably going to be one of the most common for a new murmur. It can be a papillary muscle rupture post MI. That will happen in a couple of days after, especially if it's an inferior MI. Then infective endocarditis can affect any valve, but commonly the mitral and aortic, and tricuspid if it's in an IVDU. Rheumatic disease can present with a mitral murmur. So previous rheumatic disease can present with mitral stenosis, but if they've got like current ongoing Jones symptoms, then it's more likely to be mitral regurg. Atrial myxoma is a benign tumor, commonly in the left atrium, because it sort of like flaps against the mitral valve. It can present with the same murmur as mitral stenosis. And it can cause problems, so you can refer to cardiology. For aortic, a lot of these we've discussed already. Aortic root dilatation can happen in certain infections, so ask for other infective symptoms. Yeah, I think that's it. We've talked about IV drug users and infective endocarditis in the tricuspid valve. Okay, let's move on to tide all the time or fatigue in the vignette. I don't know if I have the question actually, but I meant to. Oh, here. So on the Socrative, what do you think we should ask first if it just says tide all the time outside? So I've got a short answer, but don't worry if you're not sure. Okay, so I've got some answers. So here, people are saying someone said golden minute. Yes, correct. But what I was trying to get at is what kind of tired is it? I've also got a question about the DVLA. So I was saying if if they're like presenting to ED, I said you should inform, sorry, it's their responsibility to inform the DVLA before their assessment. So here, yeah, so while in the interim, they inform the DVLA that that they're awaiting assessment. After the assessment, the doctor like gives them a diagnosis and they document it in their records. The patient still has to tell the DVLA, but they'll have more clear guidelines about um, like for how long are they not allowed to drive, things like that. For example, like with epilepsy, depending on whether there's a structural cause that's found or not, then there's different like timelines. Some other people have said like, is she falling asleep or still able to carry on with their day, which actually is sort of what we're trying to tease out. So we need to know what the patient means by tired. People can mean different things. So classically, we might think it's reduced energy levels, but actually they might be saying that they're, feeling sleepy at certain points during the day, which is kind of different. And more, you need to screen for safety in that case. They can also be using this to describe mental or emotional fatigue. And a concerning thing is if they're using it to describe muscle weakness, because weakness implies that it's like neurological or muscular rather than like just like feeling drained. Some people might also say tired to feel like to explain that they feel like fatigue after exerting themselves. So people with heart failure will feel tired because they have such bad shortness of breath. Fine. So again, the history of the presenting complaint is very like so we've asked these things, and then you have to ask about associated symptoms. All of those, you'll basically be doing a systems review because there are so many causes of tiredness. I think I have a slide, but I'm not 100% sure. But there are different causes of tiredness. You basically need to do a systems review. The other thing is to do a very brief depression screen. So psych, obviously in fifth year, but you need to recognize that mood disorders and anxiety disorders can cause like proper like physical fatigue. And so just quickly screen, are you having any episodes of low mood, things like that. And here the social history is important. So you're asking about sleep, um, sleep hygiene, but also I mean things like are they snoring? Has their partner noticed them snoring? Because that can point you towards obstructive sleep apnea. Ask them what they do for work, um, about caffeine intake, foreign travel. So some of the things that can cause fatigue are infections, things like TB, HIV, can first present with tiredness. Any major life events, so again, asking about like psych symptoms, but any triggers like bereavement or being made redundant. You can quickly screen for like neglect or domestic abuse. And it's also really important when when you're asking about the diet, because obviously you're going to screen for like vitamin deficiencies, asking about like green vegetables, meat. At this point, you can also screen for an eating disorder. Do you have any like do you have any concerns about your body image or things like that? Or a tactful question like that? If they're describing sleepiness rather than tiredness, again, check if they're being safe with driving. Have you ever fallen asleep whilst you're driving? Oh, we do. Okay, we have a differential diagnosis for tired all the time. Um, I've split it. Okay, so this first box is primary like sleep disorders, so insomnia or OSA, and psychiatric disorders. Secondly, endocrine causes of being tired. So thyroid disease, both hyper and hypothyroidism can present with tiredness. Addison's, Cushing's, pheochromocytoma, and diabetes can also present with tiredness. Especially like type 1 diabetes, you might miss in a young person. Then any sort of big like organ dysfunction, organ failure can cause tiredness. So heart failure, but also like liver failure, chronic kidney disease can present with fatigue. Other cardiac causes are ischemic heart disease and infective endocarditis. What are the things? Obviously, malignancy. One of the mnemonic that they use to screen for cancers is flaws. We'll discuss that later in constitutional symptoms. But the F in flaws is fatigue. So make sure that you're not missing an underlying cancer, which is why for tired all the time, it's best to do like a big system screen. There's a list for all the systemic symptoms that you need to ask about. It's just in the next section. I'll show you. Um, Finally, infectious causes of tiredness. So long COVID. Um, you can just ask about any recent viral illnesses. EBV and CMV. Um, so these are causes of mononucleosis. So if it's a young person, for example, recently moved to uni, a very like prominent lymphadenopathy, HIV, TB, Lyme, you can ask cover all of those with like foreign travel and other risk factors for HIV. And there are some other, so multiple sclerosis, it's a young woman. Again, this shouldn't really come up because it's a neurological presentation, but in some people, fatigue is the first presentation of multiple sclerosis. You can ask if it gets worse after taking like a warm shower, for example. Investigations, again, you want to be thorough, tired all the time because it's very like difficult to know, so you might as well do all of these bloods. Obs again include the lying and standing blood pressure to look for orthostatic change, and you can do a BMI as well. Underweight BMI, so less than like 18 or so, can present with fatigue. At this point, you can do a pregnancy test. And in the blood, so all of these things, HbA1c for diabetes, IgA for celiac, bone chemistry to look for metabolic bone disease. And then the second line, these are like additional things that you can do based on the history. BNP if it's something like heart failure, B12, folate, and vitamin D if you think there's like a dietary insufficiency. Viral serology, so that will cover like EBV, um, HIV, etc. And an autoimmune screen if you think that's going to be relevant to cover things like SLE, rheumatoid. Fine. And then fever. Okay. Fever, again, as a presenting rate, has a really broad differential, like with tired, like with all the weight loss that we're going to discuss soon. They should, in there, if you tell them, can you tell me more? They should give you some of the other symptoms and then that will lead you down a certain presenting complaint. Otherwise, do the system screen that we'll discuss. Um, Fine. Again, so the differential diagnosis, I've tried to split by this first group is infection, but sort of systemic and can cause like pyrexia of unknown origin. So they don't necessarily check for them first, but can cause a prolonged fever over a couple of days. Um, the next one, it's important to remember that the vasculitides can cause fever. Look for any skin changes, any sort of unexplained systemic symptoms. So some of them can cause hemoptysis, renal problems, etc., abdo pain. Sarcoidosis can cause fever and also IBD flares. Any malignancy can cause fever, but these are key ones to look out for because they don't have a specific, like, oh, this is a lump or this is my cough. Renal cell carcinoma, especially, can cause pyrexia of unknown origin, and then the blood cancers. And then here, if you think that someone has sepsis, if they're presenting and the examiner tells you that they have a low blood pressure or their sats are really low, then you need to look for the source of infection after managing them, and we'll discuss sepsis management. But there are different sources, just green like top to bottom. So brain, meningitis, encephalitis, endocarditis, pneumonias, for GI infections or abscesses, especially if it's after surgery, it can be an intra-abdominal abscess. Urinary infections, and then when you're doing the E of AT, you're going to uncover everything and look for skin, like cellulitis or joint infection. Also looking for any devices. So look at the catheter, look at any central lines that they've got in to see if it's like a device-related infection or ventilator-associated pneumonia. And then in terms of sepsis, so sepsis is organ dysfunction secondary to an infective cause. So there are these different signs. The key thing to note is that the temperature can also be reduced. You don't need to look for like a really raised body temperature, but below 36 is also concerning. You can also see the carbon dioxide. If it's low, then they've been like increasing their respirate a lot. And then asking if the patient is immunosuppressed when you're taking the history is important because if you're suspecting neutropenic sepsis, you'll know from lab med that it's different management or different empiric antibiotics because you want to cover things like Pseudomonas. I'm sure you've been told the sepsis 6 like a million times, so obviously give 3 and take 3, and also say they're going to escalate to a senior if you're like talking about it in OSCE Viva. And so there's one question on the Socrative about fluid resuscitation. I think I know they say like don't you don't need to know exact doses, but again for the emergency things, I think it's best to know like a couple key doses if you can. So I appreciate it's a really long vignette, but basically he has sepsis with a really low blood pressure, 85/50. And you know it's septic because the white cell count is raised and the CRP is raised, rather than just like systemic inflammatory response syndrome. Perfect. So a lot of you have answered correct. Oh, sorry, all of you have answered correctly. So this is a 500 ml bolus of 0.9% sodium chloride. And a bolus, so it means it's given over 15 minutes. After you do any intervention, so when you're doing your A to E, after you do any intervention, just check again to see if there's any change. So here you would recheck the blood pressure and check if it's improved. Okay. Next. Okay, finally, we're doing weight loss and like night sweats. And we'll discuss the system screen that I've been like dropping this whole time. Again, on the Socrative, what do you think we should ask first if someone presents with weight loss? Lovely, thank you for your answers. So a lot of you have said the things that we're going to talk about. So firstly, is it intentional weight loss? And specifically quantifying it. So how much is lost and over what time period? Um, yeah. Secondly, thirdly, if it's associated with a change in appetite. So certain things like malabsorption will cause weight loss with a maintained appetite, whereas certain cancers will reduce the appetite. Cancers and like psych disorders, things like that. Okay, so this is our systems review to screen for malignancy or whenever you can't really understand um what the diagnosis is, you can just ask all of these really briefly at the end. Okay, so systemic symptoms, asking for fever and fatigue, um, any new lumps or bumps, anorexia or anemia. So obviously you're not going to ask for anemia, but ask for exertional symptoms, or general fatigue. Then weight loss, drenching night sweat. So you need to explain to them it's your sheets are soaked overnight. Then, okay, starting from the top, so neuro, any new headache. It's especially concerning if it's like a morning headache or associated with vomiting or changes in, like, for example, if it's worse on straining, because it can imply that there's a space-occupying lesion, raising the intracranial pressure. Any new focal neurological signs or any visual changes, sensory deficit, any new weakness is really concerning. And then ask if they've had any seizures. And cardiorespiratory symptoms, checking for chest pain, palpitations, any new ankle swelling, then rasp, shortness of breath, hemoptysis. Endocrine symptoms will cover all of the like endocrine causes of like weight loss and night sweats. Flushing and sweating will cover things like thyroid and pheochromocytoma. Thirst and polyuria for diabetes. Episodic headache again for pheo. Pigmentation will do adrenal insufficiency. Then rheumatological symptoms and heme symptoms. Any new arthralgias, skin changes, And then for heme, especially when you're screening for the blood cancers, you need to ask for like the three. So anemia for red blood cells, bruising or mucosal bleeding for platelets, and then for white cells, you can ask about recurrent infections. GI symptoms, starting from the top, so dysphagia, then dyspepsia, any change in bowel habit, nausea, vomiting that's unexplained, so not associated with like gastroenteritis, any unexplained bloating, new jaundice, or blood, so from the top, so coughing up blood or blood in the stool. For gynae symptoms, really important to screen for gynae, by the way, if it's a young, sorry, if it's a woman, in any presenting complaint, especially if it's like anemia, remember to ask about periods. If you think that there's like an endocrine thing going on, remember to ask for if the periods are regular still. So any pelvic pain, any unexplained blood, so bleeding in between periods or post-coital bleed or bleeding after she's had the menopause. Okay, and then psych symptoms, quickly screen for low mood and any sleep disturbances. Our differential diagnosis, again, covers a lot of what we've already talked about in unexplained fevers and tired all the time. Obviously, there's a whole section that we need to consider for weight loss that you don't consider in fevers, which is the GI causes. So dysphagia can just like actually reduce your appetite because you can't swallow anything. Ulcers is the same, like pain on swallowing will make you eat less. Malabsorption can be things like celiac, previous surgery, so gastric bypass. What else? Like any of the IBDs, short bowel syndrome, and then infection. That might be it. Let me just see if there's any other. No, so we finished this octave, and that's all of our presentations. Finished slightly early. Let me know if you have any questions. I don't have the feedback form right now. I forgot to make one. So I'm going to put a link in the chat. I hope you're all in the chat. If you're not, then if you could just hang back for a second. No, sorry, go back to the slide before. Yes. Yeah, otherwise feel free to yeah, leave. Thank you. That's it. Yes. The BBAMN is just a mono that someone in my house came up with. Thank you. Sorry, I don't have the form. I forgot to make one, but I'm going to put the link onto the WhatsApp chats. Are you on those? Okay, cool. Thank you.